But what about prevention? What role does foregoing prevention play in the rising costs that we face as a nation? Well, we don't really know. But boy, that would be a great topic for public health systems and services research. And it would help us address some of the critical issues in our country faces. So cost has been a major driver. But another driver has been some of the abuses in the market by the insurance company. And this is something, an area where there has been pretty much uniform agreement, at least there was uniform agreement until the bill passed, in which case not much is agreed upon by anybody. And that was some of the problems in the insurance market. We've all heard the stories about somebody who has health insurance. They go in, they get their knee replaced, and let's say it's $100,000, and the bills are all submitted to the health insurance, and the health insurance company says, you know, when you filled out your application, you forgot to mention that you stubbed your toe 10 years ago, and you went to the ER, so we're going to deny your health insurance retroactively, rescission. We know that people who have been denied health insurance in the individual market because they have a pre-existing condition, or the cost of that insurance is so high that it's unaffordable. And we know that many health insurance programs have annual or lifetime limits. People have a serious illness, and they're just one serious illness away excuse me, from financial ruin. So pretty much people have agreed that this is something that needed to be fixed. So how do you fix that? Well, one of the ways that you fix that is to say, insurance companies, you have to take all comers. You have to do community rating. Insurance companies, you have to take people who have pre-existing conditions. You can't kick them out of the plan. All of these are part of the Affordable Care Act. But now you create a problem because people aren't really, people can figure out the system. So what's the next step in here? Well, the next step is that if you're 27 years old and you know the insurance companies have to take you when you apply for insurance, why not just wait until you're sick to buy health insurance? And that defeats the whole purpose of insurance, which is to pool risk. So you can't fix these problems in the market unless you require everyone to purchase insurance. And thus we have the individual mandate, which certainly has had a significant amount of conversation. And to take that further, so we've got two changes. We've got trying to fix the insurance market that pretty much everybody agrees is really busted. That doesn't cost that much because it's all on the insurance company. The next thing that you have to do is to have an individual mandate, and actually that will generate some revenue because some people will decide they'd rather pay the penalty. And then the third thing that you have to do is say, make sure, because there are people who are poor who won't be able to buy insurance. And if you're going to mandate that they have something, you have to provide assistance. And that's where the big costs come in. So that is, in essence, a very short descriptor of what's in the Affordable Care Act. And I say that in regards to the fact that, as we all know, there are certain major provisions. There's the Medicaid expansion up to 183% of poverty, state-based health insurance exchanges that allow individuals to come in and select from certain plans so that you have a much better base in which to try to get those down. Subsidies up to 400% of the federal poverty level, about $88,000 for a family of 4. Revised eligibility determination, more regulation of rate setting, and reform of a process to identify and implement reforms in the payment system to move away from the toxic system that pays for individual care to a system that looks at a more global fee. So you've changed the rewards from doing more to doing better. If the Affordable Care Act is implemented as expected, the number of uninsured in this country is expected to drop from this roughly 50 million that we have now down to 22.8 million. And this is some recent analysis by the Urban Institute. And who will they be? Well, there'll be one group, about 4 million or so, will be the individuals who are exempt from the individual mandate. And what they learned in Massachusetts, that this group of individuals were those who were right above the cutoff for the subsidy. People who can't afford the insurance, but they make too much money to be able to get the subsidy. The second group, roughly, again, about 4 million individuals, will be those who are, I look at it, $750 penalty, $12,000 for insurance, I'll take my chances and pay the penalty. The largest group will be about 8.4 million individuals who will be eligible for Medicaid but will not be enrolled. And that has always been a challenge, and one I think that reflects many of our public health communities, is how do we get everyone who's potentially eligible enrolled in Medicaid so that they can get the full benefit of these services. So what is the role of public health agencies? How can they best get involved in addressing the care? Because the last group here, roughly about 4 million, are individuals who are undocumented immigrants into this country. And they're not eligible for any of these services. Where do they get their care? How do they get their preventive services? This is an issue that local, state, and state health departments are going to have to address. How will they identify the best solutions? Public health systems and services research. These are critical issues that have to be addressed. So what we see under the Affordable Care Act is that there are critical questions, and these are questions that I think fall within the bailiwick of what is done with population health and public health research. So what happens to the primary care delivery system, particularly the roles of state and local health departments, who have been the safety net in times past? What happens when everyone gets health insurance? We addressed this whole issue with the Vaccine for Children program, if those of you remember when that program was rolled out. People used to get their health care, their vaccines from their local health department. Now they were eligible to get their vaccines from their doctor, so the Vaccine for Children program. Many local health departments wondered how they were going to survive if they could no longer run vaccine clinics. Yet you had to counterbalance that with any time someone got referred across town to go to a public health clinic, not everybody's going to show up. So isn't it better to get the child to have their vaccine when they're someplace where you can actually stick them with a needle or give them their immunization? What are the changes? I think that's something that needs to be studied. How will the revenue streams change? What will be the roles of health departments within the accountable care organization environment? How can you link in the prevention role of public health in this environment? How do you pay for it? What should a public health department charge for prevention if they're part of an accountable care organization? And then what are going to be the impact upon programs? On the MCH, where we know that we've had some integrated service delivery models, how's that going to change under the Affordable Care Act? What's going to be the impact upon the immunizations, such as we saw with Vaccine for Children, and for newborn screening? How are we going to do the follow-up if a child is part of an ACO? All of these are key questions that individuals sitting in local health departments, as they try to think, I'm trying to survive the budget cuts, I'm not even thinking about the Affordable Care Act. Researchers in public health systems and services can help them think through these and identify the best practices.